So you've made it through the operation. Now it's time to begin living with your new organ. Each person will go through a unique journey after their transplant, and it's common to experience some form of complications. The prevention and management of complications involves a meaningful partnership between you and your transplant team at the University of Minnesota. During this program, you'll hear from transplant doctors as they explain some of the more common complications, the warning signs, and an action plan should you experience something that may indicate rejection or other problems. This is your organ now, and it's critical that we work together for your overall health and long-term well-being.
Acute rejection is basically your body trying to reject a new organ in you, it's not recognizing your lungs, which are not what is normal for you.
Acute rejection is something we see usually in the same hospitalization within the first week. You can have an acute, which is within the first 24, 48 hours, a subacute, which may be within the next week. And those are things that we see fairly rapidly, that your body clearly is not accepting the organ as well as we'd like, and we may need to do fairly aggressive interventions.
We do bronchoscopies and biopsies in the lungs to find a rejection. So in the first year we do it many times, even though you're not having any symptoms, we do them, and sometimes we find it. And sometimes patients may have symptoms. It could present a simple thing as cough, or may have shortness of breath, may have fevers. But most of the time we find it because your breathing tests show that your lung function is a little bit lower than what it was, or your chest X-ray shows something new that wasn't there. So it's very common that you may not have much symptoms. That's why we see you in the clinic as often as we do. The sooner we diagnose it and sooner we find it and treat it, the better it is to protect your lungs in the long run.
Chronic rejection is something that is happening more slowly over time, where your body is more accustomed to the organ, but is still not accepting it entirely. And you may see such things as scarring or poor function of the organ over time. For chronic rejection, be very involved by taking the medications as directed, letting your provider know as soon as you feel a change in symptoms, and following up with your clinic appointments religiously, so that if there are changes occurring, medication adjustments can be made even before you start to see any change in your function or how things are behaving for you normally. Those changes can be picked up on routine studies.
Bronchiolitis obliterans organizing pneumonia is basically a condition where there's inflammation in your lung.
It's more of a scarring along the airways, and it's something that you would feel as shortness of breath developing over time. It can happen if your medications aren't optimized, and it's a primary reason why keeping your drug levels at the appropriate levels is so important, and following your breathing tests, even if you feel okay. Subtle changes can be reflected in the testing rather than symptoms.
There are some infections you might have had before transplant that we get concerned, and we automatically put you on treatment for those conditions or suppressive therapy.
For that reason, we target exactly the organisms that you have with preoperative testing. So as much as we know about those organisms ahead of time, we direct your therapy postoperatively. So if you come in with an organism that we know is resistant to several antibiotics, we won't be using those around the time of surgery. Instead, we would use those directed to your colonized organisms. If over time you start having infections, those would be recultured and treated more appropriately to you as a new recipient of the lung organs rather than your prior infections. Following a lung transplant, you are definitely more susceptible to airborne infections, and you want to be careful of such environments as a farm, where there could be more organisms in the air that have been stirred up in the soil. Also around any farm animals, such as poultry, can definitely have airborne organisms that you don't want to try and get into your system, because you will be more susceptible as an immunosuppressed person. The best way to protect yourself after receiving new lungs is to be very aware if you're feeling at all stressed or weak, and not be in large groups of people at that time, and especially waiting to get to a more stabilized state of your immunosuppression. So immediately after transplantation, you'd want to limit contact with large groups of people, or people you know who might be sick, or children maybe in daycare, and wait until you are really fully recovered. Once you have a stable dosing of your immunosuppression and you're feeling good, then you can broaden your contact with other people. But I'd still be very cognizant of the fact that you don't want to be out in large groups without knowing you have some protection, whether it's a mask, hand washing, that sort of thing.
Only the lung is exposed to air all the time. Now, air itself is not a problem for the lung. Even though you've had a transplant, for the most part, it's not a problem. Sometimes, some things are major problems. So avoid all construction areas because there's so much dust in that area, and you could again be exposed to not only the dust, sometimes even the fungus called aspergillus. It's there in the soil, it's there everywhere. If you're going to do woodworking, wear a mask, because that constant exposure to that tiny dust particles creates a lot of inflammation in the lung, and that is not good for the lungs. If you're lawn mowing, you shouldn't do lawn mowing, but if you're going to do it, wear a good mask. So it's those kinds of things. But otherwise, if you're just say, I'm going to go out and walk in the road, in a regular road, just go walking, that's fine. That's not a problem. But if you're going to be in an area where there's a lot of dust, a lot of soil being kicked up, those things you should avoid. Never pick up a cigarette again. If you smoked before, you can never smoke again. Or if anybody else is smoking in your family or in your home, they shouldn't be smoking in the home anymore. They should be smoking outside. So it's important that your family members, your loved ones should also quit smoking, or at least not smoke in front of you. All of these things, what we worry is it may cause inflammation in the lung, which in turn lead to rejection. Diabetes is unfortunately a fairly common problem after lung transplant. If you don't know what diabetes is, it's a disease where your body cannot control the blood sugar level correctly. We all make insulin normally, and so when we eat, our blood sugar shoots up, the insulin shoots up and controls the blood sugar and tries to keep the blood sugar within a good range always. And patients have diabetes, your body is not able to make the amount of insulin it's supposed to make to keep the blood sugars under control. So what happens is you have high blood sugar levels, and having high blood sugar levels that is not very well controlled in the long run can cause various damages to your body.
Diabetes is a complication most often associated with the need for prednisone following transplantation. Prednisone is a medication that helps reduce your response to the new organs, and is a critical component of immunosuppression. But a side effect is that it causes your body to produce more resistance to insulin. For this reason, you may need to start insulin to control the blood sugars after transplantation. And it's not something that you yourself can really moderate, except with exercise and diet, to keep your weight more normalized and to follow your diet carefully so that you keep it well regulated. But given the doses of the steroids that you may need, or the prednisone that you may need, this may be beyond your control sometimes. Hypertension is when your blood pressure in your system is above a normal level, and it's not something that you can really feel in your day-to-day activities. And the reason you want to keep this under control is because it is a very high risk for stroke. The strain on your heart is also elevated if your blood pressure stays at a high level. The blood pressure is really a measure of how high the blood flowing from your heart moves out into the rest of your system. And you want to keep it at an optimal level so you have good blood flow to your brain and your other muscles and organs. But you don't want it too high because then it does strain your heart and can cause risk of small vessel rupture in the brain, which is a stroke. The best way to prevent it is, again, to maintain your medications at the optimal level in conjunction with your healthcare provider, because they'll be monitoring your blood pressure every time you come to clinic. They'll be watching the drug levels, and they'll have a better sense of where you are at with your blood pressure in relation to your new transplant and into the medications you're taking. The reason that you may be at risk for cancer following transplantation is, again, your immunosuppression that's necessary to not reject the organ. Your body normally, when your immune system is at its optimal level, can keep cancer growth in check. When you suppress that ability, cancers can begin. It is not all types of cancer. It can often be more related to lymphomas or skin cancers, but they can be very carefully monitored and can be treated if a cancer should occur. A mechanism to take care of yourself at the risk for increased cancer is to use sunscreen, stay out of the direct sun, wear hats, protective clothing, and to be aware of it. Make sure that you're following up with a dermatologist on an annual basis, and to be sure that your dermatologist knows that you're immunosuppressed.
But most commonly, it's the skin cancer or another kind of cancer, what we call PTLD. PTLD stands for post-transplant lymphoproliferative disorder. And the symptoms may be I'm feeling more fatigue, I'm feeling more tired, I'm having, I don't have an appetite, losing weight without trying, having loose stools, maybe shortness of breath. So that is why we sort of always encourage you to call us with any new symptoms. You've just had a transplant. Yeah, we have made a big surgery for you. You might see a big scar. It might be right across your chest, right below your breast, or it might be right in the middle of your chest, on your sternum. You might also see holes in your chest where we had put big chest tubes in. Hopefully, if things are going well, and which is what majority of our patients do go through, it's fairly things go smoothly, the wound has healed by the time you left. We usually say if there's nothing going on, just leave the wound open and it will heal fine. So by the time you leave the hospital, you really don't have to do anything for it. Now, the chest tube sites, so that is where the tubes were put in your chest to drain all the fluid and the blood that's coming after surgery, those holes may stay longer. Normally, as long as it is not leaking any fluid, you can just leave it open. And whenever you come to the clinic, and we'll be seeing you fairly often in the first month to 2 months, we'll know if there is something happening. We can check those and say, okay, yeah, this is a problem, we need to treat it. But for the most part, despite being on the immune suppression drugs, your wounds don't get infected. Now, in some patients, it does happen, they do get infected. And it might happen a few days or a few weeks after you leave the hospital, or it might happen while you're in the hospital. If you're in the hospital, we'll follow it, we'll check up on it. If sometimes it means opening up those wounds a little bit, draining the pus out, giving you antibiotics. And sometimes we even may send you home with what we call wound vac. Think of it as a suction right on the wound, so it's draining all the extra fluid out, allowing the healthy wound to sort of develop from the bottom of the wound. But for the most patients, your wounds will not be a major problem right after you leave the hospital. So you've just had a big surgery, and you're thinking, when can I do things with my hands or carry things, carry grocery, do laundry, driving? These are all the things that you start thinking about, when can you start doing them. Yes, your wound might have healed. Your skin looks like it's healed up well, but that doesn't mean inside of your chest that things have healed up completely. So at least for the first 6 weeks to 8 weeks, you have a restriction. And what we say restriction-wise, when you're lifting anything, it cannot be more than 10 pounds. Be careful with any kind of twisting action. Twisting from right to left, left to right, pulls on the scar. As long as you're watching out for those two types of actions, you're probably okay. We also have you see a physical therapist, have you go through a pulmonary rehab. They will go through what kind of exercises you can do and what kind of exercises you can do both to keep yourself healthy and get stronger while keeping the restrictions like we mentioned. Now, driving you would think is not a big deal, but it is a big deal for two main reasons. You're on a lot of pain medications, narcotics. If you're taking narcotics, you're not supposed to drive because it's almost as driving under influence. Your reflexes are not as good, especially on those drugs, so you shouldn't be driving them. And second, if you do get into an accident and the airbag comes and hits your chest and the chest is still healing, that'll cause a lot of problems, a lot of pain for you. So those are the things I would watch out from after having had this big surgery. When you breathe in, the air is going through your windpipe, it's going through your lungs, and it's going into the small air sacs in your lung. But what we're attaching when we attach in the lung is basically two hollow tubes. And the air should be able to go smoothly through those hollow tubes. And when you attach two hollow tubes, it should stay hollow, it should stay open. Unfortunately, sometimes what happens, it starts closing down. Instead of staying open like this, it starts closing down completely like this.
Airway stenosis is an uncommon complication following lung transplantation, but can occur because we're connecting the airways of the donor to your primary airways. It can happen to either the right or left side because we connect each lung separately. And what happens is, as the suture line that we use to connect the two airways is healing, it can scar and close down. And what is usually noted is that you may get more short of breath, or there's areas of lung that are collapsing on imaging. If that occurs, it's usually treated with having you come in back to the hospital in the bronchoscopy suite. We will look at the airways with a scope, and if they are truly getting tighter, open them up with a balloon, and if necessary, place a stent across the airway till it heals in the open position. Acute lung injury is usually seen within the first 72 hours after transplantation and is something that we would see on the x-rays and noted by your blood test immediately following surgery. We will occasionally have it occur later than that, but again noted by the recipient as shortness of breath or a change maybe with fever, change in x-ray even after they've started to feel well initially. The acute lung injury is seen on x-ray as the lungs not having as much space for oxygen exchange. And when that occurs, it's very similar to acute rejection, and we need to have you stay on the ventilator, be supported, and be treated with medications. And much of it is waiting it out for the lung to recover for itself. Diaphragm dysfunction is very unusual following lung surgery, but it can happen, and the main injury is due to the nerve that runs to the diaphragm to help it move, runs right along where we need to connect the new lungs to the heart and airway. This most commonly is injured if there's a lot of scar from prior infections in the chest cavity itself. So it's not terribly common, but if it occurs, what happens is you feel more short of breath because your muscle isn't there functioning to help you breathe well. There are treatments that we can use to help repair this, but in general it can be a longer process to get over. And so we're quite careful during surgery to avoid that nerve.
Sometimes, if you're having a lot of symptoms, that is shortness of breath, needing oxygen, or your lung is collapsed, we might do a surgery to help it. What we do is think of your diaphragm as bellows. It's normally like this in your chest on both sides. This diaphragm becomes very high like this. And when it's trying to function, this diaphragm goes down when you take a big breath, and this diaphragm sort of goes up, the other one. and making you more short of breath. What we do is we pull this diaphragm down and keep it flat and tighten it there. And that way, when this diaphragm is functioning, the lungs expand like they're supposed to. And this is not counteracting the effect of the good functioning diaphragm. Even though the diaphragm dysfunction sounds scary, but for most patients, it's not a problem when it does happen.
A pleural effusion is when you collect fluid in the chest cavity that sits outside the lung. It's fairly common after lung surgery for any reason because the body normally makes fluid that sits between the lung and the chest wall so that the lung can expand and contract with every breath, and it's like a lubricant. The problem with a pleural effusion is when it starts to collect and become so large that it presses on the lung tissue because fluid is more dense than the air in the lung tissue. When that occurs, you need to have that fluid drained, either from the tubes that were placed at the time of surgery or possibly as a separate procedure with the radiologist placing a small tube to pull that fluid off that space so that the lung can re-expand fully. Instability of the breastbone following chest surgery is usually a result of the fact that we have to enter both chest cavities and they're secured in the center by the breastbone. When the chest cavity is closed after the lung transplant surgery, the ribs are stabilized and brought back together with suture, but the breastbone itself is usually secured with wires. And the reason is they're stronger and more stable. It is possible, however, for those wires to not secure the bone because the bone is either weakened because of deconditioning prior to surgery or the immunosuppression needed after surgery for the transplant. You'd feel motion in the center of the chest where the bones are not quite solid, and you'd have kind of a rocking motion. You might have pain, discomfort, or you might feel the wires have a click, like they are moving against each other. So it's uncomfortable or painful, and you can generally feel it happen over time. It's not an instant feel, it's that you can gradually feel the motion occurring over time and becoming more painful. If that's the case, what we have done is a separate operation to remove those wires and then plate the sternum in particular like you would plate any broken bone. And that can help secure the bone because the plates are a little more strong, but difficult to place at the first operation because the ribs have not yet secured together. Well, every medication you are taking or will be taking will have known side effects. Some are more common side effects than others. Trust yourself. Once you start taking medications, realize that if something doesn't feel right, it could be medication related, and you should immediately talk to your pharmacist or your provider. Do not stop taking the medication because there are so many factors that are changing in your body with the transplantation that assuming it's one medication or the other could be very detrimental. The key is to recognize that something doesn't feel right and to speak to someone you trust to make sure that adjustments are made immediately. If you get to the point where you just can't manage your medications or you feel like they are the cause of you not feeling well, you absolutely need to come to the hospital. That's a very clear indication that it's not only are you not feeling well, but things could be dramatically changing in your system due to the transplantation that need to be addressed immediately.
Being compliant with your medications consistently is very important. It's hard work. It's one of the most difficult things we ask our patients to do is take your medications, especially when you're feeling sick, you're not feeling up to it. It is what is keeping you alive and healthy, and hopefully keep you alive and healthy for a long time.
You are given so many new medications, and they are extremely complex to the point where there's dedicated education classes so that you really understand what this new part of your life is about. And the key to successful lung transplantation and a great outcome for yourself long term is taking these very complicated medications. The structure, the when to take them, how much to take, and how they interact is critical. You can't stop one medication one day, take two of the pills the next day. It will really alter your outcome. Following transplantation, your medications become a critical part of how you're going to do long term. And even over-the-counter medications need to be discussed with your primary care provider because the drug interactions can be unexpected with the types of medications you are now going to be expected to take routinely. It's critical in this process that you always let your providers know any change of medications at all, any hospitalizations, any clinic visits. And something that's happening with your home provider, your primary care provider, must be related immediately to your transplant team so that that becomes part of your records, and we can discuss with this primary care provider whether that's an appropriate change or whether it's a change that may not be the best interest for you now that you've received a transplant. Once you go home following a transplant, you're going to be rather inundated with the expectations. You're going to become an expert in medical care. The requirements to log your medications, your temperature, your weight are not to harass you into good care. It's really to let us know that if you're having a fever, it could be the first sign of an infection that needs to be treated aggressively. Or if your weight is going up, that you may be having trouble with your heart, your kidneys, your liver, all sorts of things that may be important or could be something very easily managed by a change in medication or a change in diet.
We want you to do it especially in the first few weeks after transplant so you get to know your health. You understand what is going on with you. We are partners in this endeavor. We want you to stay healthy and stay in your home doing the things you love. What you do in transplant is very important. When we ask you to follow and get a blood test on time, I would recommend that you do so because we want to make sure the drug levels are appropriate. If your drug levels are not correct, you might be more prone to get rejection. We want to make sure your kidney function is okay. Make sure your potassium level is okay. If it's too high or too low, that can be life-threatening. So we need this lab test to make sure that you are staying healthy and that none of these will bring you into the hospital or put you at risk for lungs failing.
Following transplantation, the initial clinic visits, especially upon discharge, seem incredibly constant. You have to come in every other day, once a week. The testing seems to go on and on. Yet they're vital to making sure that your initial recovery goes as smoothly as possible. And small adjustments can be critical to your feeling well. So it's important that you make these appointments, that you bring family members so that they are learning about your process, and that you don't arbitrarily or without telling someone miss appointments, because that could mean you're very ill, and we are going to be very concerned if you don't show up. There is never a stupid question, and that if you have anything that comes to mind, that you should be contacting your coordinator or your provider to get the answers, because everyone wants a great outcome. This is a very privileged situation, and we want to make sure that you get the most optimum care. And that has to start with you, because if you don't let us know how you're feeling, how this is affecting you, we don't know how to help. And we really want to make sure you do well.
The goal of this is for you to have a good life so you can go do the things that you want to do. We would like to see you come back as in 10 years or 15 years and say, "Hi doc, how are you? I'm fine. Okay, see you back," and say, "You did this, you did that." That's what we want to hear from our patients. So it's important that you do your part, because without you taking care of your medications, making sure your blood pressure is okay, making sure your blood sugar is okay, making sure you let us know if any new things are happening in your life with symptoms, more shortness of breath or cough. we won't be able to take care of you as well. We have a big team here, a great team. We have great coordinators, and you know them by their name. I'm sure all of you know your coordinators by name and their phone numbers by heart. They are a great resource. They know how to track us down. They know what's going on with you, and make sure that if you need any help, they'll get you into the clinic, and we'll be glad to see you. Despite all the complications that we have mentioned, we've talked about before to you, and you may be experiencing some of them, we still can manage many of them and let you have a good life. And we want to be a partner with you.
We definitely see our relationship with you as part of our team. This is a huge commitment that we make to you and that we need you to make to us. To embark on such a big, life-changing choice really requires a team that's committed to being there for each other, giving each other accurate information, filling out the forms, the coming to the appointments, taking the medications. This is something that we know will take a lot of commitment on your part and that we commit to making available to you on our part. And I truly believe at the University of Minnesota, this is an operation, this is a program, this is a care that we provide for you for the rest of your life.
We trust this information has been beneficial for you and your caregivers. Please review it again as needed. Your entire healthcare team here at the University of Minnesota Health looks forward to partnering with you. We honor the gift of transplantation by working together to help you regain and maintain your overall health.